Hi everybody, today I'm talking with Dr Rhys Thomas, who is a consultant neurologist and scientist at the University of Newcastle in the UK. And we shall be talking about mitochondrial epilepsy, his research, evolution, and gosh, lots of other things to do with epilepsy. If you're new to the channel, please subscribe and press the bell icon for notifications of our weekly videos. Stay tuned. I would like to introduce to you Dr Rhys Thomas, a gentleman I have known for quite a while now, although how many times have we met in person? Maybe once? I don't know. It's crazy. But Rhys just does, honestly, I'll get Rhys to elaborate in a second, but just does some incredible work for people, families, cultures, the whole shebang really, and around the world affected by the epilepsies, and goes into the research side, the care side, and yeah, part of too many bodies. And we were discussing which hats you were going to wear in this conversation, but I will let you take over, Rhys. Tell people about yourself.
Oh, that's lovely. Thanks for the introduction. So I'm a card-carrying clinical neurologist. I look after adults with epilepsy up here in Newcastle. But my primary employer, which really means the main part of my job, is I work for the university. And in doing so, it's investigating causes, consequences of epilepsy. Sometimes that's genetic causes, sometimes that's consequences such as risk and sudden unexpected death. But probably the most unusual part of my working week and my job plan is that I'm also a consultant in the Mitochondrial Centre up here in Newcastle.
So mitochondrial, can you explain that to people, please?
Yeah, my apologies. So mitochondrial. So as you know, there are multiple cells all throughout the body, and all of your cells, bar one type, have this little powerhouse within it, the mitochondria, that are a crucial part of your metabolism. And so high energy cells need lots of energy, and that might be muscle or it might be brain. And so one of the consequences of having mitochondrial problems is that you can get mitochondrial epilepsy. And that's what we look after up here in Newcastle, kids and adults. And also, obviously, you can run through families. So we see multiple generations of people up here.
So how does mitochondrial epilepsy differ from other types, more commonly known, slightly understood types?
It is a really lovely area to work within because there are, it really repays the time you spend in the clinic to see those patterns and see the patients within it. So not everybody is the same. If you're going to pick a pattern, it's a mitochondrial disease often runs through families, through the maternal line. And so, if mum's affected, then the children might well be too, but men can't pass that on. Mitochondrial epilepsy might come in different ways. Some might look like what they call a progressive myoclonus epilepsy, which where people have problems with balance, jumps and jerks and seizures. Some might have seizures that you'd see in other clinics too, but with these additional metabolic crises that we call stroke-like episodes, that have some of the characteristics of migraine, some of the characteristics of a seizure, of focal status, and can leave a scar if it's not treated aggressively. And it's really that that we try and work hard to avoid, because you can't have too many scars and metabolic crises without it starting to pay a price on the brain.
I'm just thinking, I'm going off on a bit of a tangent here, but obviously you know that I'm quite familiar with scars of the brain and having or attempting to have those removed. If a person has mitochondrial epilepsy and they do end up, do they end up having to have some scar tissue removed? But then I don't know if it's genetic. So then therefore would you end up potentially with a scar tissue in another part of the brain if it wasn't dealt with properly?
Oh, Tori, it's pretty grisly. Yeah, so people do pick up scars all over. Certain parts of the brain are more likely to have the scarring than others. But it's a part of a progressive disease because we don't have a modifying treatment. And so even if we had a treatment, even if there was a medical or surgical way to cut out that scar, the brain slowly thins over time as well. And so a lot of these stories are cut short prematurely.
Gosh, so is there, I mean, this is a bit of a tough question maybe, but like, is life expectancy considerably lower for people with mitochondrial epilepsy?
Yeah, it is. It is. And but I wouldn't say it's all doom and gloom. So within the mitochondrial story, there are lots of different trajectories. And I think the best quality of epilepsy care really can help. It does add years to life and good years to life as well. People get diabetes there too. And similarly, really good diabetes care really helps. But you see people for whom maybe the diagnosis came late, or maybe they just didn't like the way that the news fell with them, and they've avoided services and you see people present, you think, oh gosh, if we could have had our hands on you 10 years ago and treated you in a different way, we could have, you'd be in better nick than you are now. And so we don't really have a disease-modifying treatment for most of the mitochondrial diseases, but good quality epilepsy care, diabetes care is essential.
So what research are you involved with when it comes to this type of epilepsy?
As well as sort of being a clinical consultant up here, we're housed within a Wellcome Centre for Mitochondrial Research. And probably the most, the work that I'm closest to is a clinical cohort. So everybody who comes up here would be invited to be a part of our registry, where we can invite people to treatment studies. We get natural history data. We have a standardized assessment every time we see people, ask for biological samples, and we can use that for, as I say, natural history studies, for prediction modeling, for looking at how the amount of mutation in different tissues affects what's happening elsewhere in the body. There are lots of weird and wonderful things with mitochondrial epilepsies and disease in itself. And one is the fact that the variant in the mutation, if you like, is not seen in the same amount in every tissue. And so we get spit samples and blood samples and urine samples. What I really want is a brain sample, but people are unwilling to give that in clinic. And so I'm having to make an estimate as to how much of the proportion of the cells are affected in blood, and then guess what's happening in brain.
It's like unequal distribution, like inequality of distribution.
Right. Absolutely right. And you can get people, for example, who'd have a very mild brain problem, but it's all diabetes muscle for them, or people for whom you're certain it's mitochondrial and you've got to get a muscle sample to be able to prove it because you can't find it in their blood.
It does sound so interesting. I've said in multiple, you've probably heard me say it a million times as well, but it's this research and meeting people like you that gives us the sort of the energy, the oomph to go on a bad day. And just hearing a little about your work is brilliant. Could you just explain to us, mitochondrial is not, if you have something going up with your mitochondrial cells, it doesn't automatically mean one is going to have epilepsy, right? So you've mentioned diabetes. It could play its game in many different ways, correct?
Absolutely right. So there are certain patterns that hang together. So some people will have maybe a bit of weakness around the shoulders and the hips, and in their 60s and 70s, their eyelids will be heavy or their eyes might not move so well. They'll only have a muscle problem. And yet other people will have, as I said, an epilepsy that might go along with a learning problem eventually over time. It's very, very different. And the weird one is it can vary within the family. You can have somebody who's diabetes dominant in an epilepsy family or the other way around. And I've not had anybody give me a proper explanation for that.
Is that that be epigenetics, or we just don't know?
And that's the fun of it.
That's amazing.
That's what if I worked in an area where all the answers were laid out for me, I'd be bored. No, but it makes it very difficult when you're giving information back to parents, because one of the things that we are really excited about is, so if somebody like me, a male in their 40s, turns up to our clinic with mitochondrial disease, I'd clearly give me the focus of my attention, but I'd be really looking for the women in my family who have not yet had children, because it's passed through the maternal line, and we're really keen to give as accurate as we can sort of pregnancy counselling, because there are things that we can do now to help people that we used not to be able to do before. So you may have heard about the mitochondrial donation program, which needed a change in the law to get it through. It's what people call three-parent babies, but that's just not fair at all. So it's where you take a donated mitochondria, put it into the egg, and then you could have a child where there's a really good chance that there wouldn't be a mitochondrial problem in the child. And that's so exciting to be part of that team.
No, but I think stuff like that tends to worry quite a lot of people. We've got to go natural. And I feel like saying, well, look, my brain is natural and I'm not so keen on it, with the seizures. So could you just put it into layman's terms for us? Why isn't that scary? Why is that cool rather than frightening?
I think that for me, the reason why it feels like a really elegant solution is it is replacing a battery pack. There's no part of the mitochondria, even though it's genetic, there's no part of the mitochondria in the self that contributes to your personality. This really is an energy provider. And if nature has given you flat batteries and somebody offers you a recharge, I think you take the recharge, I think.
People also don't need to worry about like their potential grandchildren, that it's going to go ooh and faff about with your child's genes and scary. You're going to have a mutant,
Wouldn't life be so interesting if it could do that? But this is really, I mean, it's critical but relatively inert. This isn't sort of a viral thing that's going to replicate and take over a cell.
Oh,
It's not going to spread in a different way. It's not even got concerns such as genetically modified crops or something. This is really just giving you a top of the range battery pack, and it could be absolutely. I mean, you'll hear lots of researchers who say their dream is to be put out of a job, but as we're bringing this in, there could be a generational change within the UK if we get this right, to reduce the amount of people who live with what it can be quite a scary and nasty condition.
Yeah, and especially if you've got several people in your family affected, it's like sounds harsh, but I would just be thinking, well, who's going to go next?
Totally. It's like the families who have people with Huntington's in it or something like that.
Right.
You marry into a family, suddenly your life partner, she gets this illness that you've never heard anything about. It's devastating, changes mobility and personality. And then you realise that your children have got a chance of it, and many of them will have it, and their illness might be the same or worse as your wife had, and you end up in a caring role for 2, if not 3 generations of your family. I mean, there are people out there, and they are so strong and inspirational, but they probably would also choose to have had the mitochondrial donation, I think.
So how common is it, this type of epilepsy?
Mitochondrial disease, to me, sort of teeters on the brink of it's a really common rare disease. And I suspect that the more we look and more we push for it, you're going to find a lot of people who've got a degree of mitochondrial dysfunction. It might have a role in some Alzheimer's subtypes, schizophrenia subtypes. It might have a role in some common disease. But the rare mitochondrial diseases, I don't know. We've probably got 1,000 people on our books in Newcastle. We cover the north of England, Midlands and Scotland primarily. There's another specialised service in Oxford and another in London. So we're probably talking 2,000 adults on our books. I'm not sure.
Well, it's 2,000 more than there should be, especially given what you said about this research. And do you know what? The more and more I read papers, I attempt, and learn about the research that we've got out there, which is like just crazily diverse. It's like everyone has got to have something going on, really, statistically. Well, there's no such thing as normal, right? And the longer that we live also as humans, like life expectancy is supposedly still increasing in this country, not quite sure, but then more and more things are going to show their ugly faces, right?
Well, that's how statistics work. That's why you're so grateful if you meet somebody who's got both, Crohn's disease and lupus and depression and something. It's because they've taken away one of the illnesses that should have come to you. That's how statistics work.
And do you know, I've just bought a new book actually, and I can't remember what it's called, but I'll put the link under this anyway. But it is about statistics and mathematics and how it's completely and utterly relevant to every single part of your life, virtually. It's just seen generally as though it's a scary, like, ooh, thing, don't touch it, or you had a bad teacher or whatever. Like, I was awful at maths, so I had like coaching on the side because of memory issues, and I actually did okay, but I still loved it because I just kept asking, which I think is really important in science, like why, I don't understand, why, and it brings out like your inner child, right? You should never let that go, I don't think.
I completely agree. So I remember sitting in an audience where there was an American prof who was talking about the work that helped him win a Nobel Prize, and what I took away from that is he solved a problem that I'd never had considered was a problem. There's a kind of a cartoon in lots of textbooks where they show how sort of chemicals go across the synapse. And I'd never really thought beyond the cartoon that actually clearly this little circle doesn't empty, and he was really asking how does the circle that holds the chemicals, how does that open up and dump those chemicals into the synapse? And you think, what a great question. I didn't know that was a problem, and suddenly solving it gives you a Nobel Prize because it was hard and it's got impact beyond the answer you've provided. You're right. Asking the right why questions and remaining curious.
I was talking to a little friend of mine, little as in 3, and I was trying to explain to him, he loves vehicles and I love aircraft, so I was trying to get him into the aeroplanes, and then I was trying to get him into spacecraft, and I said, no, but it goes up like this and then it goes straight, and he goes, yeah, but why? I said, well, gravity, like, it's only 3, but why? But what? And I don't know how to explain, sorry. And it's another great example, and I think that should totally be encouraged. Everybody, we need more people in the sphere, right, of research, of any type of brain research, but especially, of course, the rare epilepsies. And just bring out your inner child. It's not a bad thing. It's a brilliant thing.
I'll give you a why question if you want, Tori.
Go on.
So a friend of mine is interested in kind of evolutionary biology. Asked me, so why does epilepsy exist? And why do humans get it, but other animals don't? And you thought, oh, other animals do. So, well, not as many as you think. So cats and dogs do, because they're a human construct. They've been inbred rapidly for domestic circumstances, and the same with cattle and other livestock. But if you look at outbred animals, there aren't many people with epilepsy. And if you think about it, it'd be hard to be a fish or a dolphin or a bird who seizes, because life is short
a bit dead.
under the circumstances. And we know that there are other forms of epilepsy that have occurred in the animal world. You'll be aware of Cronut, the sea lion. There's Canute, who is a polar bear who had an autoimmune epilepsy. And there are some animals that do, but not many. So is there something uniquely human about the brain, about how quickly our brain develops so rapidly, and that epilepsy is part of what makes us human? That part of what, the big brain that we've got, it came with epilepsy. And I don't know the answer to that, but I'm keen to try and find out more.
That's a really interesting question, but also quite I don't know, because okay, what are the benefits of epilepsy? Unless one is, having ecstatic seizures, even those that can be dangerous. And it's like, are we officially inbred more than we realize? I don't know. What could be the positive thing for it, of the epilepsy?
I don't know the answer to this, but if there was, if our brains grew very rapidly through some time of our sort of evolutionary process, or if some of the trade-off for getting a rapid brain was the excitability of it, the learning components of it,
right.
Then it could be something about what makes us rapid learners. All great communicators, that epilepsy just came along as a byproduct of that kind of network activity, and it could be just with us. See, I don't know the answer to this. It's just me probing in the dark, but people have talked about maybe schizophrenia, and the networks of brains of people who get schizophrenia are a trade-off for people who tolerate brain injury better. The networks are better for an insult, in terms of the organisation of it. So if you wanted to be let's pick the Neanderthal who coped with getting a club to the head better, the trade-off was a tendency towards schizophrenia. Nothing is linear like that, and nothing is that straightforward. But I just, we don't have, naturally occurring gorillas with JME, or gibbons with need lobectomies. It's just not, it's just not there.
And maybe there haven't been as many generations of us as there have in other animals. What with we live a bit longer, don't we? And God, so many questions. See, this is an awful thing, but it's an amazing thing to have these conversations and to give you ideas, and people can relate to these things in so many different ways. All links to that stuff to your colleague or friend. I'd be really interested if I could have a look at that, something from that gentleman, because I love the idea of, not the idea, I just love evolution. I think it's so interesting, and it makes you more, me anyway, I become a bit more accepting of certain not so great things in life, because it's just how things work over time, how science works, and a lot of things aren't choice. And I hear a lot when people say, you can do anything, the world is your oyster. Well, that's certainly not the case for many people, as we know.
Totally. In the smallest possible way. I mean, I'm a terrible cyclist. I'm absolutely terrible. It's not my thing. Most people who are into epilepsy are sport and avid cyclists and very sporty. But I'm aware when they're trying to push us towards cycling into work and things like that, that's a very ableist viewpoint. You know, there are a lot of people who come to my clinic who will never be proficient cyclists. It's not going to be for them. But yeah, so there are tons of I can barely use a knife and fork or tie my own shoelaces, but I mean that's a different situation. But yeah, knowing your limits. But you also you mentioned my colleague Paul. Surrounding yourself with people who give you the better why questions are also good as well, because it's quite easy to live in a false bubble where you think you've got the grey areas sorted out, but there are many more grey and murky areas than you know, and that's what the great thing about clinical medicine, because your patients will always challenge you.
Yes, and they have every right to do so. And you don't have to be, I meet lots of patients, people with epilepsy and families who either think that they know it all, this is going to sound really mean, but don't like to be contradicted. And I understand that. You understand how you feel. But there needs to be like a two-way relationship between the person affected by the disease and the clinician. It needs to be open communication, and each party deserves the same respect as the other. And each party has to be open to that contradiction. Say, oh, cool. All right. I didn't know that. Why is that? Wow, that's so interesting. I think in something like the epilepsies, put your ego to one side sometimes is quite important.
If you're not prepared to be wrong, you're in the wrong business, or you're not listening. I'll tell you one that I really liked. So I had a young woman not that long ago who we were considering starting sodium valproate for really reluctantly. It as you know, issues with pregnancy, and she said, "Well, could I get my eggs harvested now and go on sodium valproate, and you can come back for my eggs later?" And you think, wow, I've never had that question. I don't know who to ask, but it feels good. And she said, well, where's the risk held? You know, how long would I have to be off the drug for you to harvest the eggs in the future? And nobody knows. There's still a role for what they call moonshot science. So people do high risk, speculative, sort of crazy science. And we mentioned Cronut the sea lion before. You know, he's a sea lion who really got poisoned with algae off the coast of California. He developed epilepsy. They're injecting, brain cells into him, and he's not seized yet. Now that could become a wonderful innovation in time, and that could hit the high street and be with us. That's moonshot science. But it shouldn't all be moonshot. There should be a real blend, and particularly if you're using money that's being raised by taxpayers or by people who are doing charity work. It's got to represent the patient group that you're dealing with. It's really challenging, though, particularly with epilepsy, because there are so many different patient stories. You get 100 people in the room, and you can get 101 different priorities. We just don't have the critical number of researchers or even the financial drive. As I would have said to you before, for every £1 spent on Parkinson's, 9p is spent on. For every £1 per person with Parkinson's, 9p per person is spent on epilepsy.
I just find that absolutely disgusting. I completely do think it's not like we should reduce the amounts spent on research for people with Parkinson's. Not at all, not ever. Gosh, no. Their lives are as valuable as those affected by epilepsy. But going back to that, the lives of those affected by epilepsy are as valuable as the lives of those affected by Parkinson's.
This is my opportunity to stand on my soapbox and say, I want at least that much, if not more, because people with epilepsy are more likely to be younger, working age children. It does impact on, there are more premature deaths in people with epilepsy. Parkinson's doesn't affect longevity in that way. Right. And so I guess if you're going to draw a map of how many lives lost or how many miserable lives there are, I think epilepsy trumps Parks. Sorry, I think we need their money. Or we can, or they're taking it turns. We can get adequately funded for 10 years and then swap back. But I'd love to see what we could do with that amount of money.
We're into equality and the valuing of lives of people from all backgrounds, and it should be the same value of life no matter what your disease is. Everybody matters.
We've been so used to the situation for so long, I think we're not angry enough. I think people should be angry about the situation. Epilepsy has been a Cinderella medical specialty for a little while, and I think people have been able to dismiss the clinicians and people with epilepsy, and I think people should be much more furious about the inequality. It should drive them.
It's amazing that I'm here, and I'm only here because guys like people like yourself have saved my life multiple times.
No,
I think if I was in, it's so true though. It's so true. But people are even shocked that, oh gosh, here she is, lardy-darring on a podcast. She must be absolutely fine. And just because you can't see this, because I'm not shaking at the moment, or I'm not falling because I'm not having a tonic or a tonic-clonic, it doesn't mean that these, that I'm not doped up on drugs, and that I'm not this isn't this, and that we've had to give up these things in our lives. And at least I'm able to, at least in a way, articulate this. Many people don't have that, and we need to give these people a voice, right, Rhys? The people out there who are as worthy as us, if not, sometimes more so, no doubt, like lovely people out there. Why are we leaving them behind?
Tori, I've never known whether it's a blessing or a curse that people with epilepsy don't always... There are times of their day and week where they're better than other times, if you know what I mean. People with Alzheimer's are poorly all throughout their time. Their memory's poor, and people with Parkinsons have problems with their mobility. But, people will see you, and they'll see the best version of you. And people therefore won't realise what it's like at other times, the very dark times. And I'm not sure if that's in terms of advocacy, in terms of putting our, making it clear to other people just how important the area is for clinical service improvements and for research. I'm not sure if people really get that. Maybe it's something about just how dramatic the change is between being well and unwell that doesn't allow people to imagine themselves being there. But maybe you kind of imagine yourself slowly developing a memory or a movement problem. There is an empathy disconnect.
And I love the word that you've used there, empathy rather than sympathy, because of course that's what everybody with a rare or condition or an epilepsy or whatever would love. We want a bit more empathy rather than sympathy. And I met with a friend of mine. It's a long time ago when I was very, very mentally unwell. And but I'd come out of hospital and I was an in-between period. I would go back, and she said to me, "Oh my God, do you know what, Tori? I don't get it. I don't understand what's going on in your head, but I'm here for you, and you can talk to me at any time that you want, and I will never judge you. I don't get it, but that's not. I'm not here to have to understand everything that you're going through, and I forget a lot of things in my life, but I will never forget that, because that's all that we want, isn't it? Just for people to empathize and not expect that you have to be, a specialist neurologist, epileptologist who specifically looks at this type of a seizure or this type of epilepsy. No, just be a kind person. That's it.
I got that wrong for such a long time, Tori. There was a long time where I heard a lot of problems. I thought I had to fix all of the problems that came to my desk, and it was a. I remember the moment that the penny dropped. Actually, dropping some of the doctor facade and actually treating it like it was a friend or family member who comes to you with some of the problems, and just listening is probably enough. And actually, some of the solutions aren't needed. People are smart. They know how to treat their headache and their sleep problems, and they know how to do a lot. Sometimes it's just acknowledging it and providing that support.
And being honest, I think, with them too. My best neurologist that I ever had, and this guy totally saved my life as well. And he was very blunt with me. I'm quite a blunt and honest person, and I love this. And he just said, "Tori, your life expectancy is not great. Like, would you consider surgery?" And I was like laughing. I was like, "Oh my God, dude, I love you. Oh, thanks for actually being upfront and honest and open with me." Yes, he knew that he could be like that blunt, but he was able to, he knew my personality and knew that I could take that. But he told me the truth. And I should have been told that many years before, saying, like, dude, you're at high risk of SUDEP. It's amazing that you're still around now, to be honest, that you should not have had refractory epilepsy for 20 years without being considered for surgery, Exactly, it's ridiculous. But he was just like honest, open, fun, cool. And that is, and you remind me of him, actually. Yeah, gosh, I'm going to make myself vomit, sorry. But yeah. But yeah, and it's you're talking to real people, and you shouldn't have to have that barrier, that old-fashioned wall between you. Yeah,
look, some people wear a mask at work, and I know it's a protective thing, but I think the better communicators are able to be a version of themselves. It helps. And you're right about the SUDEP thing. Maybe think about. A lot of people get very squeamish about the idea of bringing it up, and if you do it in a very formulaic or a mechanistic way, it can be. But at the right time in the right place. You're only saying what people themselves have feared. I mean, if you've been around somebody who's had a full seizure and they've gone blue, and your first thought is, are they ever going to come back? They will have thought about, where this could go. And so you're not telling them anything they didn't know already. And actually, sometimes that could almost be reassuring, that you're suddenly acknowledging their fears and that they were right in, by the time you come to describe it in clinic in 3 weeks' time, a lot of that peril has passed. But you've got to, when you were at that stage and thinking, have I lost them and when's the ambulance coming? It's they're aware that seizures can be risky.
It's an absolute joy chatting with you as usual, and I'm gonna make you come back, right, for another one of these next year, because you're always doing so much amazing stuff, and the research no doubt will have come on further. If people want to check you out online, where should they go?
The most boring and corporate version of me is available on Twitter. I'm at Dr_Rhys there, where I don't talk about politics or religion, but I will occasionally dabble in sport. And I'm an employee of Newcastle University. My email's on my profile there.
Thank you again, Rhys.
It's been a total pleasure.